It's my pleasure to introduce Robert Quaife, who's coming to us from the University of Colorado. He did his medical school at the University of Nebraska, and then he trained in medicine and cardiology at the University of Utah. And then he went to Texas, UT Southwestern, where he trained in nuclear medicine, and then he was on the faculty at UT Southwestern for a couple of years. And then he moved to University of Colorado, where he's been on the faculty and has sort of risen through the ranks to a professor, and is one of the few people who's really a true multimodality imager. You know, he does nuclear, echo, CT, and MR, and he has a lot of expertise in interventional, applying multimodality imaging in the interventional space, and so and has experience also in congenital heart disease, and so he's going to present his experience in the use of or interface of non-invasive imaging in the interventional lab.
Okay, can everyone hear me? Does that work okay? Need a little closer. All right, how's that? Good? All right, so thank you very much for inviting me. Yes, I've even been known to scrub in, put my hands on wires, and deploy clips before. So, you know, the point is you need to kind of walk in other people's shoes to know what they're doing. And from an imaging standpoint, I think it's really important. So we'll talk a little bit about some of the things we've been doing over the last, I would say, 15 years. These are my disclosures, research agreements, and things with other investigator and companies. Today, I'm going to talk a little bit about why we should do modality imaging, some of the advanced cardiac things that we're doing for planning or pre-planning structural heart disease. We'll talk a little bit about CT-based combined imaging, echo combined imaging, and then where we go in the future. So what are the rationale? What's the current approach or basic approach? Is we use two-dimensional imaging in a three-dimensional world. So what that requires is most people thinking about things and integrating at the same time. But that's actually fairly challenging. We do multiple modalities which have different things such as CT, echo, MR, but they have different characteristics about tissues, contrast, all of those things. And they all have different vantage points or views, and so I think that's a critical thing to understand. And the variable visualization of certain structures is important. We can use that as a strength, but it also becomes a weakness. So in the ideal world, we'd co-register everything. We'd understand physiologic and dynamic acquisition, dynamic processes in the heart, and we'd move those into a 3D space with the enhancement or the goal to improve our procedures, to include better efficiency and safety. And that, a lot of that is yet to be proven. So how many know what this is and where it is? This is a two-dimensional image, it's fluoroscopy. And if you notice, and I don't know, is there a pointer here? But does this point? No, it doesn't. Ha, okay. No, all right. But anyway, you can see this structure. It's a Amplatzer occluder device, which is in the interatrial septum. But most people don't know where that is. And the only way you know where that is if you've had 10 or 15 years of experience putting this in. So we need to know what kind of device it is, where it is. We need to, what are the key features before we put this in? Where is the placement? What are we going to do with it? Is the 3D sizing? What's the size of this defect? What are the chambers or structures that are adjacent to it that we need to think about? Are there appropriate rims or shapes that may make it a non-go? And then lastly, are there anomalous pulmonary veins that it doesn't make sense to do this procedure that should have a surgical closure? So again, all these things need to be known, but aren't necessarily picked up from this fluoroscopic image before. So we have to use other modalities, echo, CT, and other things. And I think that's sort of the basis for where we want to go, and this is planning an ASD closure. So here are some of the structural heart disease interventions currently available. TAVR, most of you are used to with aortic stenosis. Some of the mitral clip procedures, either with the mitral clip or Pascal device, are currently under study. Perivalvular leaks around prosthetic or bioprosthetic valves, melody valves in the pulmonic valve position, ASD, VSD occluders, and then left atrial occluder devices such as Watchman or others. And so what's important about all of that? It all requires advanced cardiac imaging to know where you are, to be able to plan these things in the future. Either to place the device, you either have to have some sort of TE echo guidance for the placement, or you need to know sizes and other things based on pre-procedural planning. So what are the benefits of iterations and fusion? Better understand the anatomic variation in each patient. Key structure adjacencies, like where's the pulmonary vein, for example, related to an ASD. We can use smart fluoro, so we can actually mark on a system to know where it is, and you can actually see that. Navigate in real time, so you actually see both the fluoroscopic images as well as rotation. And then importantly, do that in a 3D space, not just a 2D space. And as we said, hopefully improve clinical outcomes. So where did we begin? This is about 15 years ago. And if anybody knows much about the echo, this is the ascending aorta, but there's a problem. There's this big chamber out here. This is a 70-year-old male with end-stage renal disease who had had a bypass surgery, but this is actually a rupture, contained rupture of the ascending aorta. You can see it here in a biplane format, and you can see that there's color flow in it. It's not moving, this is actually static. So what's interesting is we went ahead and trying to think about how we might be able to close that. What could we do? This is about the time that the ASD devices were coming out used in kids. So you could certainly use a TE probe and come from behind, but the ascending aorta is not well seen. This study right here is actually a volumetric MRI done 15 years ago, so you can actually see here's the blood pool and the pseudoaneurysm right there. Should we do it from the surface with the transthoracic echo? And in fact, in this case, that's what we had to do because we couldn't see it because of the right main bronchus. There were a lot of things. This wasn't a 3D technique. This was a 2D technique. There were a lot of challenges. But this shows the pre-MRA, and you can see this large area on the left-hand image. And then you can see the void of where we put the Amplatzer device in and closed off the pseudoaneurysm. So this, in this case, you can actually see on the left-hand image, and I'll show you here with a couple arrows, the minute we put that in, it started to clot off. So we had actually closed off flow 15 years ago. The patient didn't have to have surgery and was able to have a percutaneous option. So this is where we really began to be interested in doing guidance type procedures and doing it 15 years ago. So again, we've talked about this physiologic understanding. Appropriate acquisition is really important for a lot of these studies to know how we can make it better. Planning, approach, imaging methods, target sizing, perspectives are always really important about how we do these procedures. Can we define what's the best view? Cranial, caudal, things like that for our interventional cardiologists and their procedures. What planes and what structures. And then we can do direct guidance. So this is just kind of a concept. So anybody have any idea what this is? So basically it's a window and a view. You can see the countryside out there, but you really don't know what's going on. Well, that's one of the views from a castle in Slovakia. So it really depends on whether it's all about the perspective. Are you looking from inside and looking out? Are you looking outside and looking in? And so what do we do with echo? We have a tendency to look from inside out, and so-called cardiocentric perspective, whereas CT, MR, other things that are tomographic, you look from outside in. And so that perspective really becomes important for understanding how to track devices, how to deploy them, where you want to put it. You always have to think about issues with what we're doing. And so if you use CT, there are radiation risks associated with it. but we're talking about something that's a potential risk over 20 to 30 years. But often these procedures are lethal within a few years. So it doesn't make sense. You have to do a risk-benefit assessment. You can actually save potentially unnecessary interventions by looking at this. And then if you do a procedure and you never had a chance to actually put the device in, it was going to go elsewhere, migrate, something like that, and you're spending hours trying to capture it, why did you even do it? That's a risk in itself. So the benefits are accurate deciding the pathology, appropriate triage to therapy, and then planning to reduce procedural time and potentially dose. And we showed in one abstract that at least in mitral valve procedures using mitral valve balloon valvuloplasty that we reduce the dose by using 3D TE guidance. And then exact enhancement of the data for guidance is really important. So if we kind of move into the pre-planning arena, you really need to understand what we're doing. And this is one of the things about dynamic structural changes and why it may be important to do multi-phase or multi-segment sort of acquisitions in CT. You can see here that there's a little bit of right to left flow in this side, but yet it's left to right flow later in the cardiac cycle. So the point is understanding that dynamic process is important, and you can pick this up in a secundum ASD here. You also need to define when the heart's not moving, quiescent. And so those are important for doing good studies, looking at these thin membranes, all of those things. And so sometimes that's not easy to pick up, and that's why you do gated imaging. And then the dynamic size can change throughout the cardiac cycle. And so it's really, really important to think about that when you're doing the imaging. The problem is classically you're taught for coronary imaging to do end diastole. But that's not always true, and we'll talk about it in a minute. So this is an ASD pre-planning. The old way was to do a balloon sizing, go in and put a balloon in, blow it up, and then try to measure it by ice, echo, something, what's the maximum diameter. Whereas here, we can go in and do orthogonal views and see that this is on the upper left-hand corner, a very large ASD that's huge. But what's most important, if you look at the lower left panel, see how there's no inferior rim? There's no way that this device is going to stay in position. It's going to pull through. And so there's no reason to even do this procedure percutaneously. This is a surgical procedure, and you can see the volumetric display on the next one. So again, location, size, and rims are really important for defining atrial septal defects and how we can do this. We actually did a study in which we looked at this and published some data when we compared balloon sizing to actual CT. And what you can see here is in the two far ends, balloon sizing versus CT size, were actually almost identical. Whereas if you compared it to the CT size, the TE size, now these were not optimized with 3D, but these were preferred in CTs for closure, TEs for closure. And if I go back and look at it here, you can see how we miss, based on orthogonal views, a lot of the size of the ASD from top to bottom, especially in a bicaval view. And so the point was it's really important to sort of size these and understand, and we were much better at it by doing CT than balloon sizing was, or we equal to balloon sizing, but not as good as standard TE measurement. The other way to deal with this is to actually do a technique called rapid prototyping. So this is actually a diagram that we did a number of years ago in which you actually make a 3D model of an ASD. But what we did in this case is this is a CT image of that 3D model, is that I actually took this back to the CT scanner and that we actually then put in different catheters. So this is a standard Amplatz device catheter, and you can see how it's tilted up and then moves somewhat, in this case, to the right. And then you can see here the Hausdorff-Loeck catheter, which tilts it more posterior and more vertical. So by understanding the relationships, these catheters are set up to put them in different positions. You can model that using software. So you can do a center line technique, actually going, this is looking through the ASD here on the left hand, the center line technique, far left. And then you can see the actual ASD and the CT below. So the point is that you can use both 3D modeling from actual models to get an idea of what devices you want to put in, or you can use software, which is more likely what we do now, to actually model interactions, locations, and positions. And so I think those kind of concepts are really important. So the rapid prototyping and then the pre-procedural stimulation is really important. So I think these are ways of getting at being able to understand what you're going to do before you do a procedure. Most of you have dealt with TAVRs and aortic stenosis, knowing the calcified changes. You know, change in planning went from primarily echocardiography to CT, because we could better define regions and sizes in these studies in the classic either Medtronic or Edwards SAPIEN 3 valves. But we actually went a little bit further, and so we would actually do a model of the aorta. And so this is a CT-generated 3D model of the aorta. You can see on the top panel A, that's actually the CT image. The panel B is the model of the aortic valve. And then you can see in the bottom two images how a balloon blown up in that will change the orientation of some of the leaflets. So you could understand how you could rip some of the leaflets if you have an off-axis angle as you come around the aorta. So it's not a wow factor, but the concept is to learn something before you ever get there, to be able to predict when you're going to have trouble. And then the standard measurements, as we all do here for TAVR, you know, you can see the calcified cusp, you can see the sinotubular junction. There's a big piece of calcium on the upper left. You can see the area measurements that we do, but there's some in the LV outflow tract. Those are actually risk factors for dissection. And so you want to be careful. You might consider a self-expanding valve versus using a balloon expandable valve. So all of these things are important things. And then you can also look at it afterwards. This is not so much pre-planning, but this is the 3D image of the TAVR, and look for thrombosis and other things that can happen with these valves. The other place is in congenital heart disease is pre-planning. So this is a study we did a long time ago. We did TE to guide this, but this was not a fusion or a echo-nav case. You can see on top, this is a patient who actually went through and had a prior open closure of his ASD. But you have with this very inferior on the top left, see the arrow? That's a very inferior vestibular, some people, the surgeons call it vestibular ASD. And you can see on the center image by the arrow that it comes down almost into the IVC. It's not an inferior sinus venosus, but it's a vestibular ASD. And so we were able to define that. We could define the best view. The center image on the lower and the middle right actually is a coronary tree to help you define where it is. But we could define what was the best view to see it on our CT so they had a chance of looking at when they give contrast. And then we went ahead and did balloon sizing in this case, showing it was 8 millimeters, and went ahead and closed it. But it was very difficult by TE because it was a very deep IVC view and you have to kind of rotate back to be able to see it. So again, prior planning with CT told us we were going to have some issues, told us where the ASD was, and then how we could get to it, what the size was, and we knew how to do it. But that wasn't everything. How do we get there? It seemed like it would be better to do something else. So we needed this kind of imaging fusion, structural heart disease. What are the issues? You know, structural heart disease interventions require those multiple tasks, and it's patient variation that becomes our trouble. Many of these tasks involve chamber valves, things like that are not well seen, and so we need to see them better. And the other thing is that we're working on something that 2D fluoroscopy and technology is a rail system. So if you think about PCI, how does that work? People put a wire into the vessel, inject contrast, it's in a contained area so they know where they are. But if you're in a 3D space, that makes it very hard to look at. So we're going to try to make that better by doing some of the fusion or combined imaging modalities. So this is an interesting, the military's known it for a long time. So night vision is very good for defining structures, i.e., things in there. But that doesn't tell you where a body is. And the other thing, and I'll go back here for a second, is on the right-hand image, you can see the person walking in. This is heat center infrared. So the military knew a long time ago that you actually need to have both, because you don't know what's going to get you. So you need to see the structure so you don't hit something, but you need to see the guy hiding behind the bush. So we need to know those kind of things when we're doing interventions. We need to not only see the structure, but we need to see where our pitfalls or problems are that are hiding behind. And so I think that's the important part of putting this stuff together and being able to look at it better in 3D. So what are the tasks or guidelines that we want to use for guidance? We may want to initially place the catheters. We may want to do a transeptal puncture and guide wire placement, placement of devices, verification of the correct position, be able to verify expected results. Did we close it? Did we clip it? Is the MR less? And then communication. It's really, really important to communicate with your interventionalists. They don't know where they are, and there are differing perspectives. If you think about fluoroscopy, it's one perspective, but echo's actually upside down and sort of backwards compared to those. So we need to be able to put those in the same perspective to be able to see and understand what's going on, and that's some of the value. So again, the different perspectives, and then the point of reference. What guidelines do we have as far as structure? So is it an aortic valve? Is it a mitral valve? Is it the left atrial appendage? What are those? And I think all those are critical. And then the standard views for going through this. So we're now going to talk a little bit about what are the methods in which we can go through and potentially put this data together. So the first phase was to be able to co-register CT-based data in the real-time fluoroscopic suite to try to do interventional guidance. And this is a study, mostly in EP, in which they looked at co-registration. And so if you did the bony registration versus fiduciary markers, catheters, and anatomic landmarks. The issue here is that if you did registration to the spine because there's respiration, there was 1.7 centimeters that were off. That's a lot for doing small detailed interactions. It wasn't so bad if you registered to a catheter or a heart with absolute edge registration. But the problem is with this is what? You need to make sure that when you acquire the CT, that you do it in the same way in which the study is going to be done. What do I mean? So if you're doing a left atrial appendage closure, when is the left atrial appendage full? It's actually during ventricular systole, not diastole. So you don't want to do a diastolic image like you do for coronaries. You actually want to do a systolic image when the left atrial appendage is largest. Or what else? Any ideas? You need to ensure that it makes a difference. So how do people do EP studies, say an RF ablation? They do them under general anesthesia usually, right? So how much of the time do you spend in inspiration versus expiration? So we found in our early studies that if you're doing a map, either MR or CT, for guidance for doing cardo or other systems in the EP lab, it's better to do it at end expiration because they spend more time expired, lower lung volumes, and you get a better match anatomically. And we actually tracked for a long time the bifurcation of the trachea as a mark that will move up and down for doing a lot of this fusion, and so it's an important issue. So you need to acquire the images you're going to use for registration in a similar manner. So this was our concept in 2008. So what we have is sort of a structure in which you can see the red is transparent is the CT that was acquired. This is a balloon sizing of an ASD, and the 3D TEE projected on the same thing. So we have a structure, which is the CT, if you will. we had the tissue evaluation being done by the 3D TE, and then we have the balloon sizing by fluoroscopy to actually make sure that we're doing it correct. So each one of these provides something: skeleton, tissue, and then device deployment and placement. So this was our concept in 2008. We're a long ways from there, but we haven't gotten there completely. So this was one of our early studies in which we actually, the CT I wouldn't say is great quality, but this is a person with trisomy who wasn't as cooperative as you like, but got a pretty good study. You can see right PA stenosis in this on the upper left A panel. And on C panel, you can see I actually did a center line through the stenosis, and then we could actually predict this and move it in what's called TrueView, a system, and actually tell it. And then what we did is fuse this in panel B on the bottom to show the contrast injection with the proximal stenosis and the center line at the projection that best lays out the stenosis. So you can go in and do a center line, segment out the vessel, and actually look at this. So I think these are ways that you can sort of use the tools to be able to do it. Some of my colleagues at the Children's Hospital, we published a paper a while back in which we would actually use the road mapping. They'd start to do CT, initially fuse it with MRI or CT, and then use that as sort of a boundary, if you will, for doing pulmonary artery interventions. And this is a stenosis, and they're putting a stent in the pulmonary outflow tract. So again, using the 3D data sets to be able to match is really important. And we've moved into some of the TAVR studies, in which initially in this exam, you can see stent-mounted catheter. You can see the edge in sort of orange is the CT-based segmentation of the aorta and the coronary arteries. So this was a pretty good estimation, but wasn't perfect. What are the problems? Well, the data sets may not be the current state of the patient. There may be different acquisition protocols, different table types, so there's different attenuation, or the patient may be sort of caressed or not flat. Arms may be up or down. So there are a lot of differences that make it hard. You have to be consistent. But we need better registration software to be able to do this. And this is just an example of where if you are using the aorta here, you can see the orange line. We're deploying a device, in this case a TAVR, outside the aorta. That's not good. So this registration problem is a big issue. And so you have to make sure as much as you can that things are the same, good markers, good registration, but sometimes it just doesn't work. So how else can you do this? And so this is some of the C-arm CT work we did, in which you do it at the same time. So how do we do that? Many vendors are out there that can do this currently. You often do rapid pacing, so it's a steady rate. Give 5 cc's per second over 6 seconds, and do an injection in a specific place. Can be venous or can be arterial, depending on what you want to do, and then register the CT. So this is sort of a cartoon. You can see the C-arm upper left. You can see the data that it actually presents. And then you can see what you're left with. In the lower right image, you can segment that out up above in the sort of orange, and then down below the 2D image. But it suffers from angular sampling and dynamic acquisition, so it doesn't have high resolution. So this isn't a perfect system, but we can use it. How did we end up using it? In this case, this is road mapping or setting up for Heart Navigator in CT, so we'd actually inject into the aorta and allowed to actually define very well, once we co-registered, did all these things, we could get a nice model of the aorta, define the different cusps, and how good were we? Well, this is a publication in which we could actually see that the actual angle was actually very good. There was an average angle that was a little bit off as far as what's the best angle to lay out structures for the TAVR, but it's possible with this device. So we're actually injecting into the aorta with a pigtail and then doing a C-arm CT to actually define the bases of the cusps and define what's the best view for the plane of the annulus so that we can put in the tricuspid or the TAVR valve. So again, these are options. This just shows how it line up in this view, and you can see the overall advantage. And this is just the volumetric look at it, how it's lined up, how we would put it in before we would do a procedure. And then some other people have published on this and show that you can size based on this pretty well. I think Didi Wang is now in Detroit area, but I think basically it shows that it's pretty good as far as sizing between the navigator device and the circumference. There was no significant difference. So that's pretty good by CT, but not great. So where do we move into the echocardiography world? We all know that 3D TE, you can get nice images. So you can see structures and orthogonal views. You can see the three-dimensional view, but how do we use that? Well, in the 3D system, there are multiple ways to do this. So this cartoon on the upper right says you sort of have a pyramid, if you will. And that pyramid, at least in the Philips world, there are other terms, is one in which that's actually a volumetric acquisition. So that's the complete pyramid. If you look at the dark blue on panel A, that's a smaller sector, and that's the live 3D sector. So you're getting a smaller sector vertically, and you get a little bit of higher resolution maybe. On the other hand, you can do a zoom 3D, which is the yellow sector, which is the top piece, in which we show you down here, and it just gives a smaller, let me go back. This is a balloon valvuloplasty. Oh, okay, it's not wanting to play. But anyway, you can get a shorter section. You focus on a specific area, and that gives you the resolution, and I'll show you some images. So this is a standard case that we did not too long ago. You can see the 2D echo on top. You see something flapping in the breeze. That's a problem. There's a large flail with a lot of regurgitant jet shown in the right image. But how do we look at that? You can see here in 3D imaging, you can see the prolapse of the anterior leaflet with that flail. And then you can go to 3D with color and actually see where the regurgitant jet is on the bottom there, huge amount. So this is a problem, and how do we fix this? So we want to go in and do kind of multimodality fusion imaging to look at that soft tissue, that smart flow, define where we want to be, the tissue interactions with our devices, and then the single space optimal results, and hopefully with the efficiency. There are many systems out there that can do this currently. The one we work with is called EchoNav, but there are other systems out there that can do this at this point. This just shows the registrations. You have 3D on the left, upper right, you can compare it to, and then the fluoroscopic images, and I'll show you some true images here in a minute, in which we register the data, show the fluoroscopic view, so we track the 3D TE head, and then as it moves in the fluoroscopic image, we can do the 3D imaging. So there's key factors for doing fused image: standard views, coordination of the terminology when we're doing this, optimal rotation so we don't move around too much, and then understanding of the technical approach, what we want to do with the catheters, alternate views, wire paths, placement of angles and orientations, and then factors for determining correct deployment. So this is from Penny, one of our pediatric echocardiographers, in a publication she has in which we can use so-called the smart contrast. You can see we're putting in a clip, but you see the color flow here. So we're aiming for the target, but we can also generate volume sort of models. So from the 3D TE space, we can create a model of the left atrium. We can create a model of the left ventricle. And so by knowing that, you can get the optimal view. And so all of these are really important for doing structural heart interventions. So we'll kind of go through some of the first procedural steps. So this is one in which we're going to do a mitral clip. And so the first step is we go into X-plane, and we know from our previous procedure where we want to be. And what's important is you can place a marker on the interatrial septum shown in red, and then you can see. So on the left-hand side is sort of the anterior posterior, and then a bicable view, not completely turned on. And then you can see the fluoroscopic image where X marks the spot. The interventionalist aims for the red dot, because we'll check it, but that's actually where you need to be in space. Why is that important? Because other investigators have talked about the importance of transeptal puncture for doing different procedures. So foramen ovale closure, you want to be high. Pulmonary vein interventions, you may want to be posterior, but it depends on where they are. The pulmonary VADs, depending on how they are, kind of mid-ventricle or mid-ostium secundum. Left atrial appendage, you want to be low and posterior. And perivalvular leaks and clips, you may need to be posterior or anterior depending on where they are. So all of these planning you do often with CT before you ever get there, and then judge where it is in the process. And at least one set of investigators showed in this case in which looking at the transeptal puncture, again this is the bicaval view and anterior posterior with some of the models, that it saved time. That using the echo nav was much faster than using a standard TE guidance. So it's important to mark that again, top to bottom, IVC, SVC. The ostium secundum, interestingly, is not the bottom of the atrium. Everybody thinks, if we get too far down the ostium secundum, or the fossa ovalis, that we're basically going to be in the bottom of the atrium. That's not true. You may be low in the fossa, but you're not necessarily low in the atrium. So in fact, for doing mitral clips and things, you want to be as far down so you can get posterior. If you think about the atrium, it's like a sphere, right? So what you were taught from the original people is to do it at the level of the aortic valve. But that's not very deep. If you come down a little bit, you actually get more posterior and have more travel for doing the mitral clip. And so that's what we're talking about, is understanding being lower and posterior, and then you can measure the distance here, which in the NT world is 4 centimeters, and the XTR is about 4.5 to 5 centimeters. So knowing that distance when you're planning with your interventionalist is really important. So low position and more room for mitral valve structural intervention. So I'm going to show you actually an initial case. So this is John Carroll in our lab. This is our flex screen, the large screen. You can see him manipulating the catheter. You can see over here he's placing the wire into the left upper pulmonary vein. And as he jokes sometimes, I'm telling him where to go, because I can see the wire, say, going into the left atrial appendage or going above the warfarin ridge. All of that's guidance. So we set up a standard view for him to look at, surgical view, whatever, and then he can manipulate his catheters, and then we can set up models after that. So it's very much an interactive process and a lot of discussion about what's the best way to do it. And this just shows how we can steer very nicely. So we've set up models in which the left atrial appendage is in purple. You can see we've actually marked the mitral valve annulus, and you can see how it moves down in 3D space. I can tell you when I first learned to do this, it would take maybe 5 minutes to get into this position because you had to look in multiple views. Whereas in this, because you have the structure, you know where the structure is, you can move very quickly into a position to do the procedure. So it saves a lot of time in that case. These are the standard views we use, so-called, this is the surgeon's view where we define basically the axis. We can define the target, how we rotate it. You can see that we, over in the bottom left, we track the surface of the TE probe, and then we can mark in position where we want to go. But how do we really know where we want to go? And that's, we follow the color flow. So I'll show you a little bit of example. So you can see this is manipulation with the valve. into the correct position on the 3D echo on the left. This is shown on the interventional suite, and then down below, and then here's a cartoon, or the true, how we're interventioning. So we're checking how much distance we have between the valve, moving up and down. You can see him moving in and out the clip delivery system. At the same time, we're showing a transparent mark, and he can watch it on his fluoroscopic screen. So we set up the image in X-plane or 3D, whatever is best, to be able to give him an image where he needs to manipulate. And so this is real time. It's what we do almost every time we do an interventional procedure. And here's the example. So it's not too hard. We've already put in one clip, and we want to know where to go. Well, there's a big jet there, so we're aiming for the second color flow. So again, understanding, have sort of a smart contrast, smart fluoro. If you see a big puff of color, you go after it. And so those are the things that make it easy. Whereas if somebody was just doing transthoracic and trying to do an image, it would be really difficult. TEE is even harder, but it's important. And then you can use some of the technology to actually make it easier. And this is actually a cartoon showing that if you use a live 3D technique, you can actually move the plane through the annulus of the mitral valve and be able to define whether you have the clip insertion correctly. So you can move from out of the valve into, see the posterior, anterior leaflet, and then forward, as you can see with the arrows, keep moving forward in each one of the clips. So if we have two clips in place, you can see one clip, move it between the clips, and then move forward. So you're using this 3D spatial relationship to be able to look at it and look for color flow. So again, using the 3D imaging, not just looking at the pretty pictures. And this just shows the final result. There's a pretty good jet out laterally. This was a functional, so it's still not great. But if you look at the 3D, it's not horrible over there on the left. The other way we use a lot of this is in pre-procedural planning. This is a cartoon that we set up about how to do transeptal puncture, define the target, where we want to go, and then the devices. And this is actually the pre-procedural planning piece using CT. And then this is what we set up. So this is the CTA, shows a volumetric show on the left. You can see in this patient who had terrible aortic calcification, that's what's shown in red. You can see the mitral valve in this case. Well, we set that center line I was telling you about in the lower left corner. So you set the center line. We actually can move that into the 3D space and see how the center line is up the same view, same position. And then you can see the catheter in the lower right with the wires actually going through the hole in the same position. So again, looking on FOSS or where you want to be is critical, and we can plan that up front. And how do perivalvular leaks do? How do people do with this sort of guidance? The group at Lenox Hill published a paper looking at success in mitral valve prosthesis was about 89%. You added a little bit if you did a second procedure. Aortic valve procedures only about 73%. But if you look at the complications, there weren't an insignificant number of complications. Embolization, wire entrachment, perforation, death. So having this ability to do 3D spatial orientation, knowing where you are, really helps. So how do we do this? You can see here the standard echo. You can see a large perivalvular leak. You can see it in 3D. But what's the problem here? There's actually a huge one superiorly and one inferiorly. So this person was 1 month out from a valve replacement. They was fairly sick. They didn't want to do any repeat procedure. So we brought them to do a CTA, and what do you see? First of all, there's a large perivalvular leak up high. You can see it here, but it goes from the left atrial appendage all the way over into the left atrial outflow tract, about 2 centimeters. So that's pretty big, but then there's also a second one, inferior, and it's on the, you can see on the volumetric, but I don't have a pointer very well. I wish this would work, but you can see superior, and to the right is the big hole, and then inferior is one, and we'll show you it in TE here in a minute. So here we are doing the transeptal puncture. with models, not a big deal. There it is going across posterior so we can define the region. And now we put what's called an Agilis catheter in. It's a steerable catheter that we can define. So we're going after the big superior piece first. You can see here we put a catheter across. It's moving with the left ventricle. But as you watch, we'll deploy. There's one of the AVP2s that we put in that. And then what's interesting is here it looks like it's planting trees. If you look at the superior portion, you'll see sort of round little structures. That's 3 AVP2s put in the superior, and we almost completely closed it by color flow. But now what's the problem? There's still an inferior septal abnormality, so we have to go after it. But how do we know where that is? We use the smart contrast. We see that color flow. We aim the Agilis at it and get it in, and then this view shows that we were able to put a wire across it. So this procedure, when we first started, tried to do it by 2D, could take 6 hours. We'd run into radiation dose, and we couldn't finish the procedure. We had this done in 2 hours. So this understanding of where you are in 3D space is critical. We can use some of the new technologies, the pseudo-colorization or photorealization images to change the perspective, to be able to look at where the defect is. All of these important for defining where a defect is and how to close it. This just shows that we were defining the exact position, staring into it. These are 3D images showing the planted, as I call them, evergreen trees. Sorry. There on the upper left, you can see a bunch. And then on the short axis, 3D image on the bottom. You can see there are 3 up on top and 1 below. So we put in 4 devices in this patient in about 2 hours. And this is you can see there's still a little bit of a superior leak, but compared, the inferior leak is gone, and the patient, by other techniques, only had mild regurgitation. So where do we want to move forward? I won't spend too much time. But planning, we need to have better techniques to fuse data, registration of information, whether it's in the room or not. I think that's a big issue. And there's a lot of clinical work that still needs to be done. The other thing that I think is interesting is, anybody have any idea what this is? So this is unfortunately an ischemic VSD in a patient that had an inferior posterior septal VSD shown in the upper image. It's interesting. And you can see the CT images on there. You can see a 4-chamber view on top, and then you see the sort of aneurysmal chamber with the VSD moving toward the apex. So what's the problem with this? How would you do a percutaneous approach? Well, you'd have to come up the IVC, go through the tricuspid valve, go around to the apex, and then come back and come out. And most often you would straighten all that because of devices. And as you were trying to deploy a closure device, it'd probably kink. So now you can potentially change the approach and do a hybrid procedure. So what we did was we had our surgeons come in, we do a thoracotomy. We actually went percutaneously through the right ventricle and then went directly into the space. And so this shows the 3DT on the left. There's the color flow. You can see down here, this is the device going through. See how we're pulling the device into the defect. In this case, a VSD occluder device on the lower left. And then we can show the device in place. So this is the residual up here. There's still some residual VSD, but it's not much. But we can change the approach based on understanding of the anatomy using structural heart disease, 3D anatomy, but then guide the procedure This was not done with EchoNav, but could be done with other procedures. This is from Chad Kliger doing some of the work in which they look at doing transapical or cardiac approaches to get into the ventricle planning with CT, which is certainly a way to do this. And they now have some techniques that you can do percutaneous closure. We've done a couple cases in which the colleagues in the EP lab have managed to perforate the RV. And so we'll go in and put in closure devices on the way out. And so there are all sorts of opportunities to be able to do things in the future. And so fusion imaging is really important for access the distance, make sure that you aren't next to the LAD in this study, and reduce the complications, including things like a more percutaneous treatment of LVADs and other things that require an apical approach. The next generation includes bigger clips, the Pascal device, Cardioband, other things. And how do we orient that? This just shows the photorealistic preparation to be able to change the view. We can also do some things in this case in which we can use tools. So here on the right-hand image, we've segmented out the mitral valve. And if you see the fluoroscopic view, the mitral valve is there in pink. But what we've done is then set a mandatory distance with 2 lines that actually moves with the mitral valve, but that distance is set so that we actually know it's sort of the appropriate zone to puncture. So as you move this in an RAO ventriculogram or whatever, you can actually see these lines, and when you want to do the transeptal puncture for a mitral procedure, you're within those lines. It's correct zone. And so you can use all these tools in 3D once you have it segmented out to help you doing the procedures. This just shows the volumetric technique in which you could do a right heart catheterization, in which you put it across the tricuspid valve and ultimately out the pulmonic valve, doing the model system. And this is the combination fusion with 3D TE and the fluoroscopic system, and be able to find the best view. Why is that important? We can go through and do it with the mitral valve. Here's the same sort of segmentation, do the left atrium, but importantly, how do we get on FOSS or perpendicular to the valve? So as you watch, the 3D TE image and the fluoroscopy will move to get the best perpendicular view. So you can actually use this, sort of see the 3D data set and navigate. If nothing else, this becomes sort of the skeleton of the heart to actually be able to do these things and know where you are. So the only thing I would put a plug in is the last thing. There are some ways to get a little bit of reimbursement for the echocardiographer. It's pretty small, but we need to move toward something more than this. We're lucky if we get 1 to 2 RVUs for spending 4 to 6 hours in the cath lab. And so we need to understand or have our imaging specialists reimbursed as much as anybody else who are doing these procedures. So I just bring it up as sort of an editorial comment. So in conclusion, complex cardiac anatomy and orientations necessitate a better understanding of structure and function relationships, and that can be attained through advanced imaging methods. The multimodality imaging is an important tool in facilitating safe and efficient procedures, and the multiple techniques and putting them together to understand physiology and function is going to be critical in the future. Rapid advancements in multimodality imaging for co-registration. 3D imaging is going to be important, especially in advancing a lot of these procedures, especially with industry. And then the other things are fluorofusion, structural heart disease should be basically adopted as a safer, better way. Now, we don't have clear studies yet, which is difficult because imaging time and number of devices is so variable in all these. We've tried to get a handle on it. We're doing a few things like transeptal puncture, not only just time, but position and how far we're off. Things like that are possible, but how to get better outcomes with this is a little hard because it's a highly variable area. But I think it's something we're going to need to do in multiple sites. So the clinical benefits is still underway, but I think in most cases, if you just look at the time of the procedure, it's gone from being maybe 50% success rate in perivalvular leaks with 2 to 3 gray of radiation at least, to now 2 hours of procedure, less than 1 gray, and 4 or 5 devices using this technology. So I think it's really important. I'd like to thank all my people who assisted, our surgeons, our other colleagues, the people at Children's Hospital, Jane Shen, who's one of our PhDs, who did a lot of the work in the 3D lab, and then certainly our people who have worked with us, the PhDs, Ona Wink, Alex Hawk, and Niles Nyhoff, for doing a lot of this work with EchoNav. Thank you.